Okay, everybody, let's cover the anxiety differential diagnosis pathway. This will be a very quick video just because this could go on, but I've included the PDF file so that you can go to specific slides. I just wanted to basically kind of discuss how this works. So this presentation starts off with describing some of the general symptoms. So the great thing about anxiety disorders is you can really kind of narrow them down or boil down the description to just a few words, or certainly less than a sentence will help you develop differential diagnoses and or lead you to the primary diagnosis very quickly. As we know, some of the first things that we need to rule out is it due to a substance or medication? If you find that they describe that they have recently used a medication or they're coming off of a substance or medication, typically the appropriate diagnosis would be within this realm of substance-induced or substance withdrawal, and or if there's some sort of fluctuation in attention and awareness, that might be more of a what's called delirium, where they're kind of disoriented to person, place, time. That would be kind of the primary or the main focus. But if that's not there, if there's no real disorientation, but they're having anxiety symptoms, then due to a substance and it's reported, typically it's appropriate at that point that a substance or medication-induced anxiety or withdrawal is appropriate. We jump from substances then to general medical conditions. Again, delirium is usually the first thing that needs to be ruled out. At this point, if they haven't spoken to having used a substance, definitely a referral to a physician, a medical provider to rule out some form of delirium first if you find that they're disoriented. If that's not there, but they're showing signs of cognitive issues, executive functioning, learning issues, usually that's in the realm of potentially dementia, Alzheimer's, having had a stroke, and it has some sort of behavioral disturbance with it. Refer them immediately to either some sort of emergency room if those symptoms are happening, that it really needs to be checked out, or to their primary care to give them a call and figure out what's going on. After those two, we jump into then kind of more of the common diagnoses for anxiety. The first one, if a person talks about an intense sudden fear, or even common terms of having an anxiety attack or panic attack, the first question is to ask whether or not it was due to a specific stimulus or trigger. If so, you actually diagnose, or it's actually due to a specific anxiety disorder. The most common would be a phobia. So if they have a phobia of dogs and all of a sudden they run across a dog and have a panic disorder because of that, it's actually not a true panic disorder because it was actually triggered by a stimulus and not just unexpected, which is really the main criteria for a panic attack, is that it's unexpected, reoccurrent, it kind of comes out of nowhere, feels like a heart attack. But again, there's no real stimulus or trigger to it. So you really have to ask yourself at the very beginning, is it something specific that triggered it? You may have to consider more of a phobia or some specific anxiety disorder first, and then kind of figure out where it fits in. About a third of people that have panic disorder go on to develop agoraphobia, which is, folks begin to isolate. They don't want to go out due to the fear of having additional panic attacks due to crowds, not being able to escape, open spaces, enclosed spaces. So the appropriate diagnosis or at least ruling out would be agoraphobia. Typically, these people stay at home. They have trouble returning to work because of the fear that they'll have more attacks and not being able to escape. People often describe this very common, people not wanting to go to, or even places like grocery stores. Walmart is famous for people saying, there's no way I could ever go to that store. I think even kind of normal people get anxious. But these folks particularly can't even imagine going into a store where it's kind of hustle and bustle and busy like that, and they feel like they can't get out of there quick enough. There are some of the differentials, comorbids, and possible treatments for agoraphobia. Let's jump down. If a person talks about being anxious because a an attachment figure is leaving, and they get worried about being separated from them, it's appropriate then to head down and rule out possible separation anxiety disorder. Typically, this was more so included as a childhood diagnosis. However, over the years, clinicians have found that more and more adults, especially kind of older adults, have or show signs and symptoms of this, of really becoming anxious when a major attachment figure leaves, and they worry about them. And so they kind of refuse to be alone because the attachment figure is leaving. So a separation anxiety disorder certainly should be considered at that point. There's some of the differentials and possible treatments. Now, if a person talks about they do not like to go out in social situations because of what other people might think of them or judge them or criticize them, they prefer to kind of just stay at home and not go out because of those reasons, then, and it lasts about 6 months, then we're going down the road of a social anxiety disorder. This affects quite a few people. I've seen it really particularly among these kind of younger generations. Going to school is difficult. I don't know how much it has to do with kind of having grown up in the age of really communicating over the phone, and so being in social situations with crowds and social interactions and how people might be viewing them. A social anxiety disorder is kind of becoming fairly common and difficulty among kind of these up and coming generations. Now, if it's due to a specific object or situation, as I said, you can pin down what the stimulus or what the trigger is. That usually is leading us towards a specific phobia. Now, phobias can include kind of natural phobias. It can include animals, situations, bodily phobias, other phobias. I mean, there's a whole list of them out there. So if it's due to a specific stimulus, it lasts about 6 months. Most people can realize that it's an irrational fear. The thing about specific phobias, for the most part, is that people can avoid these, and so they can live very productive lives. That's what a simple phobia is. However, a complex phobia is more so like social phobia or social anxiety disorder, or agoraphobia, which is, those two are different diagnoses, right? Those are complex because it affects multiple areas of their life, and it's not something that you really can avoid, which is in social phobia or agoraphobia, it impacts their life so heavily because you really can't avoid the world. And attempting to do so heavily impairs their level of functioning. So if you have a client talk about rumination, and they're worried about a variety of different topics, anywhere from work and family, money, their health, society, no matter kind of, it goes the gamut of and spectrum of different worries, whether it's about themselves or others or the world. This is one of the most common diagnoses that you'll see in practice is generalized anxiety disorder. And the word generalized says it all. It's really not limited to a specific trigger, a specific situation. It's really about everything. In society, I mean, these were people in the past that were called kind of worry warts or nervous Nellies. I mean, those type of phrases and labels were put on them. Neurotic people. Just kind of this constant kind of simmering worry about of what's going on in their day or what's going on within themselves. Frequently, these individuals have irritable bowel syndrome and GI problems and fatigue, and it even appears that they have quite a few somatic complaints. So this diagnosis is very common. There are some of the comorbid and possible treatment considerations for them. Now we're getting down to the last few. If a person talks about intrusive thoughts or obsessions or even compulsions, obviously many of us have grown up hearing about OCD, people talk quite frequently, I think I'm OCD or he's OCD or whatever the case may be. If a person describes having intrusive thoughts and images, They can actually have what's called purely obsessional OCD, which is they have intrusive thoughts that can, and images that can have themes of aggression or harm or cleanliness, or even distress because of thoughts and feelings of guilt and disgust. And again, it can be purely obsessions. They get caught up. Most of their day, or a big portion of their day, is occupied by these intrusive thoughts. They cannot get out of them. And again, it's usually around a particular kind of topic or theme. Oftentimes people then will develop compulsions to try and reduce the stress or distress they're experiencing. So if they do sort of compulsions of hand washing, checking doors, that's usually used to help them kind of reassure themselves and control, or not necessarily attempt to control, but reduce the anxiety that they're experiencing. There's a whole bunch of comorbid diagnoses that can go along with OCD. Major depression is definitely one of them. And there's some of the possible treatments. SSRIs, antidepressants, are probably the very most common and first-line defense with folks with obsessive compulsive disorder. But therapy obviously is very helpful to go along with it. Right, the last couple, if a person talks about worry about having health issues or having an illness, we're going down the pathway of either having a somatic symptom disorder, which this usually is a person that is experiencing somatic symptoms or pains, actual physical pains, and usually they have a physical condition to go with it, but the description of the symptoms are out of proportion to the condition that they actually have. However, they seek frequent medical attention because of the symptoms that they're feeling and experiencing. If it goes beyond that, if all of a sudden they start to develop beliefs about having a serious illness or contracting a serious illness after experiencing one of these somatic complaints, really it evolves then to becoming an illness anxiety disorder, which was previously in other editions called hypochondriasis, or a person is a hypochondriac, that they believe that they have a serious illness, even though their symptoms are very, very mild. They really seek frequent medical visits to be reassured that they don't have a cancer or some sort of tumor or some sort of rare disease. You have to rule out any sort of delusional disorder or psychotic disorder as well. But this is one that I've seen quite a few clients struggle with over the years, of really this belief that they're contracting or they have a serious illness when in fact their symptoms are very mild and they've been reassured by multiple providers that they're okay. All right, last one. Here we go. Finally, if a person is not wanting to part with or discard personal items, they're keeping kind of relics and some things that are often negligible value, even kind of trash and boxes and figurines, and they're excessively shopping or starting to accumulate these usually kind of negligible valued items. This is leading us down to hoarding disorder. I think many of you have maybe watched those shows about hoarding. This can begin kind of very small, and then all of a sudden it really takes over this person's life. They begin living in a very limited space. It often becomes very unhealthy, or it becomes excessive to the point that it's difficult to navigate and throughout their home, and it creates safety hazards. So hoarding, it's a very interesting disorder. Has a lot of kind of underlying themes and underlying things that need to be treated or can be treated, and involves multiple, usually a treatment team, to help with people with hoarding disorder, because it affects their health, it affects their living environment, all sorts of areas of life. So these individuals usually need a whole treatment team to help them out. All right, that is the differential diagnosis pathway lightning speed. Refer to the slides if you want to go back and look at the comorbid disorders, differential diagnoses, and the common treatments that are associated with them. All right, there you go. Hopefully you've enjoyed.